I'm Mary Claire Wahl. I know most of you, and thank you, non-nursing and health sciences people, for listening to something that's probably different than what you're used to in your department. I'm going to be talking about a way that I attempted to improve the ethics curriculum in the ethics education in our nursing curriculum for our undergrad students. So let me just kind of define briefly what perinatal nursing is. So this is an area of nursing that has to do with taking care of pregnant women, newborns, families, that sort of thing. And it stretches from, a perinatal nurse can be an RN in labor and delivery, all the way through advanced practice registered nurses, which include certified nurse midwives, which is what I am, also neonatal nurse practitioners, women's health nurse practitioners, and that sort of thing. And just as a side, those little babies are the last 5 babies I delivered before I transitioned into academia, and I haven't delivered a baby since, so I'm proud of that picture. Okay, so overall, in nursing, we use ethics every day, so this is nothing new. And I think our department does a really great job of educating ethics throughout the curriculum. But what I've noticed, as I teach the seniors that are about to graduate and go out into practice, is that they have a hard time sometimes really applying the theory of ethics to their clinical situations. And while I did a review of the literature, I really could not identify why, but just kind of thinking about it intuitively, many of our students are, in the traditional program, they are young. And so not only do they have limited patient care experience, but they have limited life experience. And sometimes they just don't have that real life perspective to help families navigate through difficult choices. The other thing is, in this area of nursing, we face a lot of ethical dilemmas which many times conflict with people's religious, cultural, and moral beliefs, namely abortion. And so students do have a hard time talking about that and acting on their beliefs. So just to give you a little background of which ethical principles we kind of use mostly in nursing, these are the big 4. We talk about autonomy, which is the patient's right to self-determination, and that includes the right not to treat. Okay? Non-maleficence basically means do no harm, while beneficence means do good. And then justice is fair and equitable treatment of all people. Now the ANA, American Nurses Association, also has a code of ethics, and they add a few more things, such as fidelity, which is keeping promises, so keeping your commitment to the patients. That also includes things like making sure that we remain competent as nurses, and that we are professional, and that we are loyal to the patients. Veracity, of course, is truth-telling, so that includes things like informed consent when you're teaching a patient and a family about the benefits and the risks of a certain procedure that they may have. And then, of course, privacy, confidentiality is very important, and caring of virtue. And then I threw up the ethics, the Daniels-Fund principles, just to show you that while the terminology is different, they align very closely. So what is different about talking about ethics in perinatal nursing? Well, the biggest difference is that you have 2 patients. So I'm taking care of a mother, but I'm also taking care of her fetus. And sometimes the rights of one may conflict with the rights of the other. And then because of this, many times women and their families are sometimes faced with difficult choices to make. And what we want to teach our students is that these decisions they have to make are not necessarily, they don't necessarily have a right and wrong answer. And as nurses, we are the patient's advocates. And so the dilemma for us sometimes is, who is our patient? Is it the mother or the fetus? So for some examples to show you. Mandatory drug testing in pregnancy. There have been cases, not so much in Colorado, but in other states, where women who have used illicit substances during pregnancy have actually been taken to court and gotten lost custody of their child and went to jail. And what we found is that women who use substances actually will avoid prenatal care because of this threat. And so ultimately, as healthcare providers, we're missing the opportunity to intervene to screen them for addiction, and also lost opportunity for intervention and treatment while they're pregnant. Another one is prenatal genetic testing. So there are numerous tests available now to screen for chromosomal and genetic defects. And unfortunately, many of these things they screen for, there's no treatment. And so the question becomes, are women truly informed about the risks of undergoing screening tests when there's nothing we can really do to improve the outcome? And studies show that about 3/4 of women who have genetic testing done regret it later if it comes out positive, because most of the time it's a false positive. It causes them a lot of anxiety. And they say that they felt that they were not truly informed by their healthcare team of what that meant. And the other decision is, if there is a genetic problem, then women and families are faced with the question of whether or not to terminate the pregnancy. So IVF is in vitro fertilization. So this is an interesting one. Over the last couple of decades, the incidences of assisted reproductive technology has really improved. And so it is not uncommon with women with infertility to have procedures where they have medications to make them hyperovulate, and then their eggs are essentially extracted. Fertilization occurs in vitro, so in the test tube baby. It's actually a dish. And then the question becomes what to do with all of those remaining extra embryos, because they usually will fertilize quite a few at a time. And so now with cryopreservation, those can be frozen. And there's been many cases in the literature where the mother and father, the biological mother and father of this embryo dissolve their relationship. And the question becomes, whose embryos are they? And then, and so sometimes nurses working in infertility treatment centers have to deal with this issue when those embryos are abandoned. Cesarean birth is a big dilemma these days for two reasons. Many women, thanks to celebrities like Britney Spears, and that was a long time ago, but there's been more since then, have requested cesarean simply to avoid the alteration in their female anatomy by giving birth the normal way. And so because of that, they had set the precedence, and now there's more and more women asking their doctor, I don't want to have a vaginal childbirth and go through labor, I want a cesarean section. So the question becomes, at what cost? Because there is increased risk to the mother and the baby with a cesarean section. There's increased risk to future pregnancies. The cost of delivery of baby via C-section versus a vaginal delivery is 10 times more. And so it increases the burden and cost to society overall.
Well, and also now our research shows that there's a higher cost for that child to have future problems with food allergies and other things.
Absolutely. Yep. Wow. Absolutely. And then on the other side, what about women who refuse to have a C-section? Now, we say that we respect autonomy, so a woman has the right to not have something invasive like major surgery done to her body. But what about if it's to save the life of the fetus? Refusal of blood products, the same thing. Does the mother have the right to refuse blood, even if it means that she might die if she does not get it? Does she have that same right if she's pregnant and we're now risking the life of the fetus because of her refusal? Multi-fetal reductions. This is another hard one. Now, when it's pretty standard of care when there's a multiple pregnancy, so someone who's pregnant with triplets or higher, it's very common practice, because there's such a high risk to those the fetuses and to the mother because of the strain on her heart. It's common practice to offer what's called fetal reduction. And that's where they intentionally will terminate some of the fetuses to get the pregnancy to be either a twin or a singleton. So the question becomes, is that morally acceptable to terminate the life of a healthy fetus in an attempt to save the lives of the other ones? The other question might be, what about gender selection? So there was a case where a mother had quadruplets, 1 male and 3 female fetuses. Is it morally acceptable for the parents to be able to choose that they want a son and a daughter, so they deliberately choose to save the male fetus and one of the females at the expense of the female fetuses? Caring for severely malformed newborns. This is a tricky one, especially for nurses that work in the NICU. So again, at what cost, at what expense are we spending, often for futile prognoses, to take care of these newborns? And who defines what the quality of life is going to be? I have a colleague who's a neonatologist who cared for a baby with, I can't even remember the name of the condition, but it's a hereditary condition where the baby is born with skin integrity that dissolves. So the baby and these children can live for a few years, but over time they will lose all of their skin. And the huge problem with the nursing staff in the NICU was that the parents wanted to do everything to keep the baby alive. But the nurses taking care of this baby were in a position where every time they had to change the baby's diaper or just do basic care, the skin was peeling, and they could see the pain in this baby. And so that was a very difficult moral dilemma for those nurses. And then these last two, surrogacy and borderline viability. I'm going to go into a little more detail because I want to show you an example of the assignment I created to help educate nursing students. So the assignment, I chose to do a group project, and basically the students are allowed to choose their ethical dilemma. I do give them a list similar to that, and they can choose whatever they're interested in. And what they need to do as a group is define the ethical, so what is the ethical dilemma here? They need to apply principles of ethics to kind of guide either their decision making or help the family make those difficult decisions. And then finally, they need to, to consider nursing implications with this kind of topic and what they would do if they were in that situation as the nurse. And then they present it to the class. So I'm going to pass around a little case study for all of you to do. Sure, thank you. Okay. So while that's going around,
I just want to mention
yes.
The Daniels case competition this year, and Kim just left. She's one of the coaches for the undergrads. It's about a genetic engineering type of firm, and one of the issues that they brought to consulting is a rumor that they're doing genetic engineering for children, for designer babies.
Yeah.
And
well, the scary thing is that's probably very close to happening. Yes. Okay, so while you're reading over the case, I'm going to give you a couple minutes to read over it, but let me just define the difference between a traditional surrogacy and what's more common now, what's called gestational surrogacy. So about 20 years ago, I don't know if any of you remember the case, it was called Baby M. That was the first surrogate case. But in traditional surrogacy, a woman will get usually artificially inseminated by the intended parent's male sperm. And so the surrogate mother who's intending to adopt that baby or hand that baby over to the adoptive couple is actually the biological mother because it's her egg. Nowadays, it's much more common to have gestational surrogacy where the surrogate is not genetically linked. So you'll have a mother with a donor egg, the male with the donor sperm, or those could be the intended parents' own gametes. They are put together in a petri dish, and then the surrogate is artificially inseminated. So she carries the baby, but she's not genetically linked. So I'll give you a minute to finish up reading the case. Actually combines two ethical dilemmas. One is about surrogacy, and one is about refusal of the C-section. Oh, there are my patients.
Oh, there he goes, you're fictional.
That's right.
Did they sign off on this?
They gave me permission. Okay, so now I'm going to give you guys the opportunity to think like a nurse. Okay, so what are the ethical dilemmas that you see in this case?
The right to make a medical decision.
Okay, so the autonomy,
Who has the right to make it?
so mostly for the C-section part, right? Okay.
Can you repeat your question? I'm sorry.
So what do you see as the ethical dilemma? We'll start with
Oh.
surrogacy. What's the ethical dilemma? Because often when I ask students about this, they really can't think of any reason why there would be an ethical dilemma here.
Well, this is in Midge's, this fetus is in Midge's body, but it has no genetic connection to her. But the donor sperm is Ken, so whose babies is it? I mean, like, who makes the decision here?
Yeah, and that's really in cases that surrogacy has presented a problem. That's been the issue. And in fact, many countries outlaw surrogacy. We lived in Germany, and it was they just said no, you can't do that here. So they go to France to get there. Okay, so there are several ethical issues. So first of all, you want to think: is there a moral difference between a situation where the surrogate is simply a gestational carrier, or are there different rules of the game when she is actually using her own egg, so she's the biological mother? And then do Barbie and Ken have the right to insist that Midge maintain good prenatal practices? Simple things, such as, can they make her take prenatal vitamins? Can they make her abstain from smoking and drinking? Could they insist on prenatal genetic testing? And if that shows that there's an abnormality, could they insist on Midge having an abortion? Okay? And those cases have been brought up before.
So that's the question, are these things not outlined before this happened?
This is contract.
Contract.
So there are, and the big case that came out a few years ago was I believe it was in Connecticut, and a similar situation where the fetus was found to have severe malformations, and they recommended that she abort the baby. And the surrogate mother did not, that was not morally acceptable to her. It was in the contract that she would have to undergo abortion, but when she got in that predicament, she said she would not. So she actually moved to, I think it was Ohio, which is a more surrogate-friendly state, and then because of that, they could not make her. She ended up delivering the baby. The baby had multiple heart and other abnormalities, lived for about a year, but the biological parents abandoned the baby, and the baby was put in foster care. That's very sad. Okay, so moving on to the ethical dilemma of the C-section. So who has the ultimate right to decide what's best? Would it be Midge, or would it be the parents of the fetus? And then things like, are Midge's other children considered? Because potentially she's putting her life at risk. At the risk of, a single mother now, dying in surgery and not having anybody to take care of her children. So what kind of ethical principles do you think are involved in this? What applies? We talked about autonomy. Yeah. Anything else?
Respect.
Mhm.
Accountability.
Yeah.
Accountability, yep. Beneficence, if you're thinking about doing good, you want to do what's best for both the mother and the fetus, and then do no harm. You don't want to harm the fetus if you prolong the cesarean section. So pretty much every principle applies here. So I'm going to show you what the students came up with. So I thought this was interesting. They brought up the potential of exploitation of the surrogate, which was really interesting to me because I hadn't even thought of that. But more and more surrogates now are coming from places like India, Thailand, and so it kind of does run along that edge of, is this human trafficking? They brought up things like the impact on the child and the surrogate parents and that sort of thing. But they also touched on things like you did with integrity and trust, accountability. They were very focused on what were the terms of the contract, and you have to abide by that legally. So from my perspective, that kind of blended into their developmental age as students, that everything was very black and white. You don't really have, until you're in someone's shoes, it's very difficult to know. So that they were very insistent on, well, what were the terms of the contract kind of thing. They talked about fairness and respect. And then they came up with wonderful nursing implications. They talked about how it was so important that the nurse be aware of their own biases and that sort of thing, and how that could affect patient care. The nurse may face moral uncertainty where they're caring for this family, but they just, their heart, their gut doesn't like it, doesn't go with it, and that sort of thing. And then how, education before they enter into these agreements is so important. Emotional support and that sort of thing. And then finally, understanding the legal issues. And many student nurses say, even with simple adoption, which isn't simple, but it is a little simpler than surrogacy, they feel uncomfortable because they don't know what the law says they can do. They don't know if they can, when they're taking care of a teen who's giving her baby up for adoption, and the teen asks to see the baby, even breastfeed the baby, if they're allowed to give the baby to the teen, if there are even contracts in place. So they're kind of fearful of that legality part. The next case is called borderline viability. So this is a picture of actually a 22-week gestational age baby. Full term is 40 weeks. So currently, the definition of viability means 24 weeks, and that's, medically speaking, that's when resuscitation would occur. Now, over the last year or so, that's kind of been going down towards 23 weeks now is acceptable, especially if the baby is making initial attempts at breathing. The gray zone is kind of between 22 and 24 weeks, and they call that borderline viability. And the risk to this neonate overall is quite high. So about 60% of babies that are born in this gray zone will either die or have lifelong major morbidities, so complications and sequelae. In fact, at 22 weeks, about 90% mortality. Okay. So the question is, who makes the decisions? Obviously the newborn, the baby, does not have the capacity to have autonomy, so the parents make the decision. And the problem is that often these decisions are made under duress when a woman comes in unexpected preterm labor, or her water is broken and she's about to give birth. And it's not uncommon for the parents to say, I want everything to be done. And once they initiate the whole cascade of resuscitation, it's harder to take the child off of those support things.
There's a case on this just in the news, like
in the last few days.
Oh, yeah, I didn't see
I
that,
feel
but
like
I'm
it
not
was local,
surprised.
too.
Right.
Yeah, I mean,
Yeah. So I'm gonna just, hopefully we'll play this, but I just want to show you, this is just a 4-minute video. This was an example of one group that took on this topic, and they chose to do it in a skit format, and it was kind of interesting to see their perspective on it.
Good morning, so Ms. Jones. We got here to sit down and talk about your 2 unborn children. So currently, you know, Ms. Jones, that you're 23 weeks with twins. Fortunately, you do know that your amniotic sac is a baby. So as a fact, the male twin has trisomy 21 and the female twin does not. At this point in development, both of the baby lungs are very mature. We don't know if they're going to survive outside the baby. However, it does look like your daughter has a higher chance of survival than your son. So what we discussed today is what we will discuss just going forward and how we want for us to proceed with the care.
I want you to do everything in your power to save our daughter. I don't want you to keep her alive if she's going to suffer. I mean, what's our best case scenario?
So something to consider when making a decision is that statistically speaking, between 22 and 23 weeks gestation, there's only a 20% chance of survival. Of those that do survive, about 64% have short-term major morbidity. Some studies have even concluded that the percentage of survival can be as low as 3% around this time frame.
I can tell you from my personal experience as a neonatal nurse practitioner in the NICU, these infants really struggle. Oftentimes when we see preemies come into the NICU who are at or below 23 weeks, there are significant and debilitating morbidities that they suffer through. Some of these morbidities include severe infections, blindness, hemorrhage, and the placement of a permanent trach or feeding tube.
See, that's not a quality of life, and I don't want our daughter to do that.
So we respect you seeing that, but then where do we draw the line? How do you determine that what point her life is no longer considered quality? How do we keep each other accountable in that too as well? So in all fairness, I feel like saying that communicates that some lives that people with disabilities are considered to be worth less than others who are simply undesirable.
I don't know why you think you can judge what quality of life means to our child. We can't base this decision off of that. Haven't you had a point in your life that was not considered absolute quality? Do these bad times justify the quality of your entire life? That limitation determines the rest.
Okay, but I think the important thing to consider is the quality of the life that you two will have as well. You're thinking of your babies, understandably so, but if you choose to resuscitate the baby and the baby has severe lifelong conditions, that will greatly impact your lives. It will impact your finances and it will put a tremendous amount of stress on you, and this isn't something that's going to resolve quickly.
Well, working in the NICU, I have seen miracles happen. Each of these babies is an individual and should be given the chance to survive. You as parents play a huge role in survival of the baby. If you're willing to show love and devotion, the child has a greater chance of survival.
What if neither of them survive and we waste this precious time poking and prodding at them instead of our family loving them? It will just be hurting them, and I thought your job was to prevent them from harm.
If we don't do anything, that is agreeing to let them kill our babies. I couldn't live with myself if we didn't at least try.
Using palliative care, we can ensure that children remain comfortable and pass in peace. It would not be stopping all care, it would be continuing care to the end of life. We also can bring the Catholic priest upstairs to baptize the children into new life.
We need some time to think about this.
So, yeah, I thought they did a really nice job of presenting, all different perspectives on this issue. So again, I'm going to ask you to think like a nurse, and what are the ethical principles? They discussed many of the considerations, but what are the ethical principles that would apply?
Well, transparency. The fact that the parents were informed,
Right.
of the decision either way.
Doing good. Both
Yes.
doing good and doing no harm, both
Right.
in
And that's kind
competition with
of
each
a
other.
competition with each other, exactly.
Liability, making sure that even the child's needs are looked after, not just the parents.
And then another thing is justice. Is the burden of medical intervention fair to all? At what expense do we go to save this baby's life? And then And they talked about the impact of the family, but I would ask to even go further and talk about the impact of society. If we're talking about future populations with lifelong major disabilities. Okay. So overall, I tried to do a good search of the literature on how to effectively teach ethics. And there's really a lack of good studies out there that show what the best way is to teach ethics. But of course, they recommend that you teach it across the curriculum. It shouldn't just be one. You know, I took my ethics class. Good, difficult, right? And then, so to put them in different environments. And so I think that's so important in nursing because they have different specialty courses. We really need to have them sit down and think about the issues that are going to be affecting them in every area. And then we want to encourage exploring these topics in a supportive environment, which would be, you know, in a classroom setting or even in a simulations setting before they have to interact with families. We want to model respectful discourse. So this I mean, I've learned this can be very contentious in the classroom, especially when you start bringing up abortion and termination. And I've had I've had students that have really emotionally not handled this well. And so I think it's important to model it. And then make sure we're helping students identify their own values and beliefs and really understanding how their values can impact their patients.
What were some of the strategies that you approached that particular bullet? Helping the students identify their own values.
So I use reflective journaling. So in their clinical experience, every week after they have a rotation in the hospital, they have a questions, prompts, and we encourage reflective, practice. And one of them is ethics. I want you to think about. So I ask them to identify just any moment during their day that they felt something was not right, and then try to clarify that. And then I don't know if students are aware of their right to have conscientious objection, but the ANA Code of Ethics specifies that all healthcare professionals have the right to dismiss themselves from care if they conscientiously object, but they can't abandon the patient. And then we want them to focus on the patient and the family, not specifically their own goals, and then really listen to the patient's story. And that concludes it, and I would love to hear any suggestions or feedback you have for teaching this topic. Mandy?
I am just curious, in that situation, in real life in the hospital, would the nurses be the one having that conversation with the parents about the choice, or would social workers be?
Right, that's a great question. So with the case of the borderline viability, it's really the neonatologist, so it's the doctor that specializes in the neonates that is called down to really give all that thorough, these are the odds, this is what we're facing, here are your options, we can do full resuscitation, we can do nothing, we can do supportive care. The problem is that usually that decision is made under duress, and those families are often not emotionally at a place to hear it because their OB doctor has just come in and said, your bladder's broken, you're 8 centimeters dilated, you're going to be giving birth to these premature twins in the next hour. And then the neonatologist comes in and follows up with all this, and the patient isn't hearing anything. So typically what happens is all the physicians leave, and there's the nurse.
Yeah.
So while it is the responsibility of the physician to do the informed consent, it really falls into the nurse's laps. And I've had many patients ask me, what would you do? And that's such a difficult question.
So that's so similar to our world as well, or whoever that intermediate healthcare provider is, or that boots on the ground healthcare provider is being the one that's the resource and the sounding board to help navigate these decisions.
It just made me ponder if that is a time for interprofessional care of a social worker coming in to now not be a provider, but to be a separate entity. That's all I was thinking.
Oh yeah, right.
Situation.
But I think the challenge is, like you just pointed out, is that that's like a deliberate need or a deliberate access versus, you know, the person that's in and out of the room and then, I just gotta talk to you for a second, let me, you know, somebody that bounced something off of which isn't timed and so it's really great that your students get to identify that that's the reality of how the world works and the job works.
And that decision has to be made quickly.
So, and I don't mean to minimize this at all, I just think it's really kind of interesting that, I don't remember if it's Wednesday night or Thursday night, where it's Chicago everything, Chicago Fire, Chicago Med, Chicago Police, which we love to sit down and watch as a family, but there's been cases specifically on some of these neonatal, prenatal situations on Chicago Med recently, and going through this whole scenario of the contracts, the decision making, you know, all of these ethics around it. So I appreciate that it's kind of out there and being discussed more in mainstream, because this type of scenario of what we're doing for birth support or whatever I don't know what the right name is, but is so much more mainstream.
Yeah, good point.
So I don't know if that's like, I guess our students don't really, hopefully they don't have a lot of time to watch TV.
You'd be surprised.
Maybe I know. Maybe there's clips that we could pull or something to start stimulating conversations and using it as like a tool in the classroom that we can pull from some of these social media and TV type of scenarios.
Well, and this brought up,
Oh, go ahead.
This brought up a memory. So I have a friend with lupus who had cancer and survived and had several scary moments throughout her life, and she's my age. And then she wanted to get pregnant, which meant she needed to get off her drugs, and she did get pregnant, and at 22 weeks her baby delivered. And everyone said, this baby's going to have a lot of issues, he may not survive. And I appreciated the comment from one of the students who said, well, with the love and care, they have a higher risk, higher opportunity to survive. And this child did have a lot of issues, but he is now 11 years old, and you can't tell the difference between a baby that was full-term and him. He has reached his growth potential. He has no developmental delays anymore. And so imagine if they had the other decision.
Right.
You know, I mean, there's always that
Absolutely.
miraculous story.
There's that case from, I think it's the Pueblo region or South or somewhere, where, and I'm not going to get it all correct, but there was a child that was born, I think it was a girl, and she lived to be quite old. I think she just died recently. Her brain didn't develop, you know, she had brain stem, but not the rest of the brain didn't develop.
Anencephaly, probably.
I don't know that it was called that, but I mean, it just wasn't, nothing was there in just the brain stem. So her body developed, but she had no ability to interact or do anything. She became quite old. I think she passed away recently, but it was in the news a couple of years ago. Again, it got brought up about the effect on the community, the family, the resources needed to keep the child alive, at what value, because the discussion then of, is the child really there versus it being just a vessel.
Right.
And then what was that relationship? And the mother was talking about, no, I have a loving bond. I can feel that there's a loving bond back. And is that even possible with the anatomy that child has? And that whole case in and of itself, I thought was really deep and would be maybe a good conversation starter.
Yeah, there's definitely not a paucity of examples out there for students to choose from, because there are just so many.
That was fun.
Thank you.